Hi everybody. Our lecture today is Essentials of Management of Hypertension, about the basics of non-pharmacological treatment. My name is Dr. Mohamed Seleem. I am a cardiology consultant from National Heart Institute, and this lecture will be given through the course of the review course of the Egyptian Society of Cardiology. Introduction and objective of the lecture. Non-drug treatment is indicated for all patients with hypertension and at all stages of hypertension. Clinical studies show that blood pressure lowering effects of targeted lifestyle modifications can be equivalent and very important even to drug monotherapy. Appropriate lifestyle changes may safely and effectively delay or prevent hypertension in non-hypertensive subjects. It can delay or prevent medical therapy in grade 1 hypertensive patients, contribute to blood pressure reduction in hypertensive individuals already on medical therapy, allowing reduction of the number and doses of antihypertensive agents, and subsequently it can decrease the side effects of the drug. Ultimately, it can reduce the cardiovascular risk, but only the major drawbacks is the low level of adherence over time, which requires special action to be overcome. However, lifestyle changes should never delay the initiation of drug therapy in patients with hypertensive-mediated organ damage or patients at a high level of cardiovascular risk. The recommended lifestyle measures that have been shown to reduce blood pressure effectively are salt restriction, moderation of alcohol consumption, high consumption of vegetables and fruits and other dietary recommendations, weight reduction, and maintaining an ideal body weight and regular physical activity. In addition, tobacco smoking has an acute prolonged pressure effect that may raise daytime ambulatory blood pressure. But smoking cessation and the other lifestyle measures are also important not only in blood pressure but also for cardiovascular disease prevention and cancer prevention. We will start by dietary sodium restriction. There is an evidence of a causal and direct relationship between sodium intake and blood pressure, and excessive sodium consumption, which is defined that above 5 grams sodium per day, for example, 1 small teaspoon of salt per day, has been shown to have a pressure effect and be associated with an increased prevalence of hypertension and the rise of systolic blood pressure with age. Conversely, sodium restriction has been shown to have a blood pressure lowering effect in many trials. A recent meta-analysis of these trials showed that a reduction of only 1.75 grams sodium per day, which equals to 4.4 grams salt per day, was associated with a mean reduction of 4.2 over 2.1 millimeter mercury systolic and diastolic blood pressure respectively, with a more pronounced effect in people with hypertension exceeding 5 millimeter mercury in systole and almost 3 millimeter mercury in diastole. The beneficial effect of a reduced sodium intake on blood pressure tends to diminish with time, in part due to poor dietary persistence and compliance of the patient. The blood pressure lowering effect of sodium restriction is greater in some categories of patients, like Black people, elderly, and in patients with diabetes and metabolic syndrome or patients with chronic kidney disease. And these subgroups of patients are considered to have what's called salt-sensitive hypertension. In people with treated hypertension, effective sodium restriction may reduce the number or dose of blood pressure lowering drugs that are necessary to control the blood pressure, making the control of blood pressure success rate is much greater. Salt and sodium are used together the same, synonymously. In fact, salt is only 40% sodium. 1 gram of salt has 400 milligrams sodium. The remaining 60% of salt chloride is an often forgotten but likely important. So the other salt with the sodium is very important as part of the link between the salt and blood pressure. So if we will replace the chloride in the sodium chloride with, for example, sodium citrate, this will abolish the increase in plasma volume and high blood pressure induced by sodium chloride. Similar effects have been observed when sodium chloride was replaced by sodium phosphate or sodium bicarbonate. Therefore, with regard to the blood pressure effects, it's useful and more impressive to speak in terms of salt intake rather than sodium intake. Of note, sodium doesn't increase blood pressure by increasing volume. Despite an excess of sodium, extracellular fluid volume, plasma volume, and blood volume are not increased, but rather decreased in essential hypertension. And in fact, there is an inverse relationship between the plasma volume and the total peripheral resistance. The higher the total peripheral resistance, the lower will be the plasma volume, but the plasma volume will be increased relative to this given number of the peripheral resistance. High sodium and low potassium inhibit the sodium pump, increase the concentration of intracellular sodium, and drive calcium into cells, which will induce vascular smooth muscles contraction and increase peripheral vascular resistance. So this is the main mechanism behind the increase of blood pressure with high salt intake. High dietary salt intake will lead directly to target organ damage. For example, by increasing afterload, by increasing intravascular volume, and direct effects on the protein synthesis of the myocardial cell, this will lead to hypertrophy. At the same time, high dietary salt intake will contribute to increase angiotensin 1 receptor expression in the myocardial cell, and this will lead to increased concentration of the beta receptors and increase the transforming growth factors. And in the same manner, it will increase the aldosterone synthesis in the myocardium, and all these mechanisms ultimately will increase myocardial fibrosis with the hypertrophy. So the salt intake will have direct effect on the myocardial cell and will induce not only hypertrophy by increasing the blood pressure, by direct effect on stimulation of fibrosis. The effect of reduced dietary sodium on cardiovascular events remain actually unclear, and prospective cohort studies have reported an overall increased risk of mortality and cardiovascular events on high sodium intake. However, there is a proposed what's called a J-curve phenomenon, in which there are some reporting that reducing sodium intake below a certain level, which was postulated to be 3 grams of sodium per day, further will reduce blood pressure, but meanwhile will paradoxically associated with increased risk of all-cause and cardiovascular mortality in both the general population and hypertensive people, suggesting the J-curve phenomena in the relationship between the salt intake and the blood pressure. The mechanism of this apparent increased risk at low sodium intake is not well understood. Maybe beyond the blood pressure, maybe beyond the cardiovascular system at all, maybe due to increased susceptibility, for example, to infections. There is no evidence from epidemiological studies that very low sodium intake may cause harm. Although a few trials and meta-analysis suggest that reducing salt intake from high to moderate is accompanied by a lower risk of cardiovascular events, to date, no prospective randomized controlled trial has provided definite evidence about the optimal sodium intake to minimize cardiovascular events and mortality. There is other co-founding factor very important, which is the potassium. Increased potassium intake is associated with blood pressure reduction and may have a protective effect. It antagonizes the effect of sodium, thereby modifying the association between the salt intake and the high blood pressure and cardiovascular disease. Globally, usual sodium intake or consumption is between 3.5 to 5.5 grams per day, which corresponds to about 9 to 12 grams of salt per day, with marked difference between different countries in different geographical regions and even within the same country. Sodium intake should be limited to approximately 2 grams per day, equivalent to 5 grams of salt per day in the general population, and to try to achieve this goal very strictly in hypertensive patients. Effective salt reduction is not easy, and there is often poor appreciation of which foods contain high salt levels. Actually, advice should be given to avoid added salt and high salt food. A reduction in salt intake remains a public health challenge and priority, but requires combined effort and collaboration between the food industry, government, and the public in general, as 80% of salt consumption involves hidden salt in processed food. For example, jam contains salt, although it is sweaty. Other dietary important recommendation and changes. Hypertensive patients should be advised to eat healthy, balanced diet containing vegetables, legumes, fresh fruits, low-fat dairy products, and whole grains, fish, and importantly, unsaturated fatty acids, especially olive oil, and to have a low consumption of red meat and saturated fatty acids. The typical example of this is what's called Mediterranean diet, which include many of these nutrients and food. It's very rich, even in antioxidants, with a moderate consumption of alcohol, mostly wine with meals. A number of studies and meta-analyses have shown that the Mediterranean diet is associated with a reduction in the cardiovascular events and even all-cause mortality. Randomized controlled trials in high-risk individuals on the Mediterranean diet over 5 years showed very beneficial reduction in the cardiovascular risk by almost 29% compared with a low-fat controlled diet, and almost a little bit less than 40% reduction in the rate of stroke. The Mediterranean diet also significantly reduced ambulatory blood pressure, blood glucose, better glycemic control, and it has a favorable effect on lipid levels. The diet should be accompanied by other lifestyle changes. I should not depend on only one measure, such as physical exercise and weight loss. With regard to coffee consumption, caffeine has been shown to have an acute pressure effect. However, chronic coffee drinkers tend to have lower blood pressure. Nevertheless, coffee consumption is associated with cardiovascular benefits, as highlighted by a recent systematic review of prospective cohort studies, including more than 1 million people with cardiovascular events. Moreover, green or black tea consumption, due to high concentration of what's called flavonoids, may also have a small but significant blood pressure lowering effect. Regular consumption of sugar-sweetened soft drinks is hazardous and has been associated with overweight, metabolic syndrome, type 2 diabetes, and higher cardiovascular risk. The consumption of these drinks should be discouraged and abandoned. Thus, adopting a healthy and balanced diet may assist in blood pressure reduction, which will be reflected on marked and significant reduction of cardiovascular risk. The next item, which is very important, is the weight reduction. Of course, excessive weight gain is associated with hypertension, and reducing weight towards an ideal body weight will decrease effectively the blood pressure. In a meta-analysis, the mean systolic and the diastolic blood pressure reductions associated with an average weight loss around 5 kilograms will be 4.4 and 3.6 millimeter mercury in systolic and diastolic blood pressure, respectively. Both overweight and obesity, especially visceral obesity, abdominal obesity, are associated with an increased risk of cardiovascular risk and all-cause mortality. Weight reduction is recommended in overweight and obese hypertensive patients for control of metabolic risk factors, but weight stabilization may be a reasonable goal for many other people and may be associated with very favorable metabolic profile, especially in lipid control. Here is the relationship between the fat and the hypertension and the pro-inflammatory state, which is created by a metabolically active visceral fat with subsequent recruitment of macrophages, apoptosis of adipocytes, and the release of many oxygen-free radicals will increase the oxidative stress and will lead to a pro-inflammatory state. It will lead to endothelial dysfunction, insulin resistance, increase in the lipolysis. All of this will lead to increase in the cardiovascular disease prevalence in diabetes, metabolic syndrome, and even cancer. And this can occur through many mediators like leptin, resistin, adiponectin, serum amyloid A, osteopontin, macrophage chemoattractant protein 1, interleukin 6, tumor necrosis factor alpha, and many others. Here is the effect of the visceral obesity on the kidney and on the blood pressure. As you see here, the visceral obesity will lead to metabolic disorders, as I have just mentioned, like insulin resistance, dyslipidemia, glucose intolerance, inflammatory state, and lipotoxicity. Meanwhile, increased fat content inside the abdominal cavity will lead to some sort of renal compression. And this renal compression will impair significantly the renal sodium reabsorption. It will be increased. And through macular dense feedback mechanism, it will decrease the afferent arterial resistance, and it will lead to glomerular hyperfiltration, which will lead by time to renal injury. All of this will share in the increase of the blood pressure, and by time chronic kidney disease, which will impair the renal sodium reabsorption again and again, and we will enter in a vicious circle. To the left side of the screen, you can see that the direct effect of the visceral obesity to the activation of the RAS system and mineralocorticoid activation, sympathetic nervous system activation, and also there is a recent central neural mechanism involved between the visceral obesity and rise of the blood pressure and more rise of weight through the leptin melatonin pathway in the hypothalamus. All these mechanisms will increase the blood pressure in obese patients. The prospective studies collaboration concluded that mortality was lowest if the body mass index is between 22 and 25. Although the optimal BMI is unclear, maintenance of a healthy body weight, BMI between 20 and 25 kilograms per square meter, in people less than 60 years of age may be higher in older patients, and waist circumference less than 94 for men and 80 centimeters for women is recommended for non-hypertensive individuals to prevent hypertension, and also for hypertensive patients to reduce blood pressure and sharing in better control of their blood pressure. Weight loss can also improve the efficacy of antihypertensive medications and the cardiovascular profile. Weight loss should employ a multidisciplinary approach that includes not only dietary advice and regular exercise, but also motivational and behavioral counseling, because it needs encouragement of the patient to maintain this weight loss and will be translated into a normal life pattern of the patient. Furthermore, short-term results are often not maintained over the long time or over the long term, unfortunately. Weight loss can also be promoted by anti-obesity drugs and to a greater degree bariatric surgery, which is now recommended with the BMI exceeding 35, which appears to decrease dramatically cardiovascular risk in severely obese patients, and also it has a very favorable effect in diabetic patients. Regular physical activity. It's a very commonly asked question by all hypertensive patients. Physical activity induces an acute rise in blood pressure, especially systolic blood pressure, because it is a function of heart rate, followed by a short-lived decline in blood pressure below the baseline. Epidemiological studies suggest that regular aerobic exercise and activity may be beneficial for both the prevention and treatment of hypertension, and also to lower the cardiovascular risk and mortality. Meta-analysis of randomized controlled trials which examine 3 types of exercise: aerobic endurance training, dynamic resistance training, and isometric training, reduced resting systolic and diastolic blood pressure by 3.5 over 2.5, 3.2 over 1.8, and almost 10 over 6 millimeter mercury respectively in the 3 types of these exercise, but this in general population. However, in hypertensive patients, it was shown that endurance training, but not other types of training, reduced blood pressure more in hypertensive patients by almost 8.3 over 5.2 millimeter mercury systolic and diastolic blood pressure respectively. Regular physical activity of lower intensity and duration lowers blood pressure less than moderate or high intensity training, but is associated with at least 15% decrease in mortality in most of the cohort studies. This evidence suggests that hypertensive patients should be advised to participate in at least 30 minutes of moderate intensity dynamic aerobic exercise, for example, walking, jogging, biking or cycling, or swimming, on 5 to 7 days per week, at least 5 days per week. Performance of resistance exercise on about only 2 to 3 days per week can also be advised and can be very helpful in some patients. For additional benefit in healthy adults, gradual increase in aerobic physical activity to around 300 minutes a week of moderate intensity or 150 minutes a week of vigorous intensity aerobic physical activity or an equivalent combination between both of them is highly recommended. The impact of isometric exercise and on blood pressure and the cardiovascular risk is less well established than the other types of aerobic exercise. Number 5, smoking cessation. Smoking is a major risk factor for cardiovascular disease and also for cancer. Although the rate of smoking is declining in most European countries, especially in men, it is still common in many other regions, especially here in the Middle East and in the Mediterranean area, and including all age groups and including also increased rate of smoking in ladies and women. And overall, the prevalence remains high as 20 to 35% in Europe. There is also evidence suggesting ill health effects of passive smoking. It can affect also people who are not actually smoke. Studies using ambulatory blood pressure monitoring have shown that both normotensive subjects and untreated hypertensive smokers present higher daily blood pressure values than non-smokers. Smoking is second only to blood pressure in contributing risk to the global burden of the disease regarding the cardiovascular health. And smoking cessation is probably the most important single, most effective measure for the prevention of cardiovascular disease, including stroke, myocardial infarction, peripheral arterial disease, and all forms of the vascular affection. Therefore, the history of tobacco use should be established at each patient visit and should be integral part of the history. In hypertensive smokers should be counseled regarding smoking cessation and should be encouraged in each visit. Brief advice from a physician has a small but very significant effect of about 1 to 3% over and above the unassisted 12 months quit rate. This can be also improved by pharmacological treatment with varenicline and combination of nicotine replacement therapy, nicotine patch, being superior to bupropion or single nicotine replacement therapy. Combination therapy is much better. In comparison with placebo, nicotine replacement therapy or treatment with bupropion doubles the chance of quitting, while varenicline or combination nicotine replacement therapy triples the chance of quitting and increase the success rate of stopping smoking. Combining behavioral support with pharmacotherapy is very important, and it will increase the chance of success between 70 to 100% compared with brief advice alone. It should be integrated through special smoking cessation program. The last but not least is the moderation of alcohol consumption. There is a long established positive linear association between alcohol consumption, blood pressure, and the prevalence of hypertension and cardiovascular disease risk. Binge drinking can have a strong pressure effect, and it can precipitate hypertensive emergency and urgency. The prevention and treatment of hypertension, or what's called PATH study, investigated the effect of alcohol reduction on blood pressure, and the intervention group had a modest, about 1.2 only over 0.7 millimeter mercury of systolic and diastolic blood pressure lower than the control group at the end of the 6-month period. A meta-analysis of more than 50 epidemiological studies suggested that reduction of alcohol consumption, even for light, moderate drinkers, might be beneficial for cardiovascular health. Hypertensive men who drink alcohol should be advised to limit their consumption to only 14 units per week, and for women to only 8 units per week. This will be, 1 unit will be equivalent to around 125 ml of wine or 250 ml of beer. Alcohol-free days can help during the week, and avoidance of binge drinking are also advised and very helpful. To conclude my lecture, in this table of the recommendation of the European Society of Cardiology recommendation and guidelines for non-pharmacological treatment of hypertension 2018, we can say that all of them are class 1 recommendation, starting by salt restriction to less than 5 grams per day is highly recommended, and it is class 1A. It is also class 1A recommendation to restrict alcohol consumption, as I have just mentioned, to less than 14 units per week for men and 8 units per week for women. It is recommended completely to avoid binge drinking. Increased consumption of vegetables, fresh fruits, nuts, legumes, unsaturated fatty acids, especially olive oil. Low consumption of red meat and consumption of low-fat dairy products are highly recommended. Body weight control is indicated to avoid obesity, which is defined as exceeding BMI above 30 or waist circumference exceeding 102 centimeter in men and 88 centimeter in women. And our aim will be healthy BMI between 20 and 25 and the reduction of the waist circumference below 94 in men and 80 in women. This will help and reduce blood pressure and cardiovascular risk. Regular aerobic exercise, at least 30 minutes of moderate dynamic exercise at least on 5 to 7 days per week is recommended. Maybe higher level of exercise are recommended in some people if they can. Smoking cessation, supportive care, and referral to smoking cessation well-established programs are highly recommended. Thank you so much for your attention.